Okay, so good afternoon, everyone. Officers of the state and the district health departments, colleagues from the National Program on Climate Change and Human Health from different parts of the country, the specialists from the various adult and pediatric hospitals over the country, the medical officers from the primary health centers, community health centers, urban health centers, and other hospitals, and the invited speakers from Atal Bihari Vajpayee Institute of Medical Sciences, Professor Ajay Chauhan and Colonel Dr. S.C. Shaw, the advisor from the Army's Research and Referral Hospital, Delhi. Good afternoon to all of you and greetings from the Director General of Health Services for you all. Unfortunately, he had to proceed on a tour and could not join, but it was his initiative that this webinar should happen. All of you would be aware that the Indian Meteorological Department in the beginning of this month had released an advisory, as well as in the previous month also, but also this month, when they insisted on letting the people know that the season is going to experience more frequent and more harsh heat waves across various parts of the country. And in this context, there were reviews taken up by himself, the Honorable Prime Minister of the country, the Honorable Health Minister of the country, the member health of the Niti Aayog, also the Secretary of the Health and Family Welfare, Government of India, the Secretary, Ministry of Home Affairs, Government of India, and also by the member secretary, NDMA. All of these meetings concluded with some specific guidance for all the officials who are working in the health departments at the districts and the state governments, as well as for the clinicians working in adult and pediatric clinics of various hospitals of the country. To summarize, a few of them were: first, there is a necessity to ensure that there is an health facility preparedness, towards which all hospitals and all health centers would have heat stroke beds or heat stroke rooms identified along with emergency cooling procedures. And this would also be ensured in ambulances during the season. To this effect, an health facility preparedness and ambulance preparedness checklist has been circulated under the program, and you all are requested to, through the provided QR code, access that Google form and ensure that you have undertaken the necessary measures for preparedness and share the same through those checklists. Second, to ensure that there is a capacity building of the entire health workforce, both public and private, and also of the paramedics working in the ambulance. The treatment protocol, much detail of which will be provided today during this webinar by our invited speakers, should be displayed at the relevant patient care centers. Thirdly, to ensure that the ongoing surveillance system reporting of the heat stroke cases and death be ensured by all private as well as public facilities wherever qualified doctors are present. Next, to ensure that there is a continuous dissemination of public awareness messages, and in much the focus should be for the vulnerable groups. Also, as we know that under the National Program on Climate Change and Human Health, there is a provision to have a district task force under the district collectors. So there is a suggestion from these review meetings that these meetings should be held to review the preparedness at the district level, and please do share the minutes of these meetings at the program level. There should be an uninterrupted supply of electricity in the health facilities, and we have provision in the program that wherever required, solar panels can be put up so that this uninterrupted supply can continue. Ending here, I would like to invite our speakers, Dr. Ajay Chauhan, Professor of Medicine at Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, Delhi, and Colonel Dr. S.C. Shah, who is a senior advisor to the Army's Research and Referral Hospital, Delhi, to provide their insights into how we require to manage the cases related to heat impact in our hospitals, both adult and pediatric emergencies. Dr. Purvi, can you invite the speakers, please?
Yes, sir. So first, I would like to invite Dr. Ajay Chauhan to begin. Sir, if you have presentation,
yes, I have.
Yes, sir. Okay, over to you, sir. Then.
I will share it. Okay, thank you, Dr. Akash, Dr. Purvi, and NPCCHH for giving me this opportunity to speak about health-related illnesses. So, are my slides visible to one and all?
Yes.
Yes, sir.
Okay. Is my voice audible?
Yes.
Yes, sir.
Thank you. So, good afternoon to all of you, wherever you are. And heat-related illnesses are very, very important, have becoming very important these days as the climate change takes its toll. As we can see, no discussion on heat-related illness is complete without having a brief, because of paucity of time, overview of this climate change affecting one and all in the globe. So we can see that right from Europe to Caribbean, North America, Gulf of Mexico, we have extreme weather events in form of high temperatures, tornadoes, cyclones, and flash floods. And one of the example, I have made this slide from today's newspaper. This is today's Times of India on the right side and today's Indian Express on the left. Dubai received rainfall in a day more than its annual share of rainfall. So these extreme climate change events are only... is there any question? Okay. I would request Dr. Urvi to mute the rest of the participants, lest they create... okay. So as we see, it becomes all the more important for us to learn about heat-related illness and their management, because sooner or later we are going to get them in bigger numbers. So temperature. Hello, is my voice audible? There's some disturbance in the line.
You're audible, sir.
Okay.
Audible, sir.
So this 2023 was the warmest year till we started recording temperature from 1880 to 1900, some people say. So it had 86 days in which the temperature breached 1.5 degrees centigrade, and 2 days in which it breached 2 degrees. That is, and in history, it is recorded as the warmest year. So before discussing how to solve a problem, let's gauge the magnitude. In India, there are about 3,775 deaths reported between 2015 to 90. It makes it about 755 deaths a year. And if you compare it with the United States, 11,000 Americans have died. If we see 1979 onward, it comes to about 255 deaths a year. But if you take CDC data from 2004 onward till 2013, it comes to 702 deaths per year. And given that the data capturing is much more robust in their country, so we can assume that this problem is going to increase as the climate change occurs. We can see the European data also. From 1998 to 2017, more than 66,000 people died, which comes to an annual death rate of about 9,000 per year. And given the fact that Europe is half in about 80 crore, nearly 60% of our population, and it's much more cooler. So we can imagine we need to do something on our data capturing front also. We have to sensitize, we have to be sensitive to recognizing what is a heat stroke. So we have to realize that it is not only the temperature, when it is called heat wave. Heat wave is considered when absolute temperature departure from normal is 4.5 to 6.5, it is heat wave. And if it crosses 6.5 from the mean temperature, it's called a severe heat wave. In terms of absolute, we have 45 and 47 degree respectively for heat wave and severe heat wave in plains. And coastal areas, if the temperature with high humidity, if it crosses more than 37 degrees centigrade, a heat wave is declared. We have something called as a warm night also. Those of you who are much interested in, go back and read about it. So effect of heat on human body is not only dependent on temperature, it is in fact a composite endpoint of temperature, relative humidity, air velocity, as well as the radiant heat. So there's something called as heat index. This slide you can see, I have converted. The problem is our mind works best when we get to hear the temperature in centigrade. So see, if you carefully look on the y-axis on the top side, on the x-axis on the top side is 96. 96, if you convert it into centigrade, is about 35 degree. 35 degree, you may consider it to be slightly warm, but not out and out hot. But if you take 75% relative humidity, which makes it 132 or a 55 degrees centigrade, then it's a major problem for human body. So while taking temperature into consideration, we should not forget about relative humidity. And then there are two more things which make our measurement, insofar as human beings are, the effect on human beings is concerned, more livelier and more relevant. This is wet bulb globe temperature, which not only takes wet bulb and a dry bulb temperature, but also has a black globe for radiant heat as well as for air velocity. It is a very, very important instrument. Lot of prevention activity in some countries, namely Gulf area, outdoor activity, it's mandated to have this wet bulb globe temperature. And whenever the wet bulb globe temperature rises above a threshold, uh, the laborer working there is supposed to take rest depending on the temperature. I will discuss that table also in the fag end of my presentation. So we see that wet bulb globe temperature is a much more better index. It comprises of all four. So insofar as heat and human physiological adaptation is concerned, it is all heat related illnesses are, the primary pathophysiology is an imbalance between input and output. And input of heat is, besides the environment, is through fever, shivering, tremors, convulsions, but the main input remains by which heat in our body, core temperature increases the exercise. It can increase the core temperature of the body by as much as 20-fold. Output, human body dissipates heat through, in fact, all bodies dissipate through convection, conduction, and radiation, as we have all read in our physics classes. But the main method of losing heat from human body remains evaporation. However, it is ineffective if the relative humidity rises above 70 degree. And radiation heat loss is also one of the very important mechanism. So that is the reason we ask and advise people to wear light colored clothes in summers. As insofar as conduction method of heat loss is concerned, although it is not very important physiologically, but in treating patients of heat, it becomes the most effective method, because the conductivity of water to heat is 25 times that of air. So we use this to perfection when treating heat stroke patient by immersion cooling. So how does thermoregulation in our body takes place? Hypothalamus preoptic nucleus is the main site. It compares the blood temperature to the peripheral temperature and senses what has to be done. In case of cold, it activates noradrenergic or the sympathetic system. However, in case of hot weather, it activates parasympathetic nervous system, namely by increasing vasodilatation of the skin, thereby increasing the heat loss as well as activating the sweat glands to produce more and more sweat. And this is a slide taken from US Army Research Institute of Environmental Medicine. Heat loss from human body is a complex of lot of conditions. From left to right side of the screen is, if you see, it's a coronal section of human body, from core to muscle to fat to vascular skin to avascular skin, then clothing layer. And heat has to lose through all these layers one by one. And in the center is the central blood compartment, from which at every level there is a transfer of heat either to or from the site where there, and it is a multiple of lot of other factors. Central blood temperature, namely heart rate, body surface area, VO2 max, which is the amount of oxygen being consumed by body secondary to exercises. So we see that human thermoregulatory model is a complex one, which is dependent on a lot of factors and their interplay with each other. We come to yet another important point in human physiology, which is acclimatization. Acclimatization happens basically right from the all the organ system of the body down to the cellular level. Thermoregulatory set point is altered if one works in heat for a long time, and sweating rate increases by 4 to 6 times. Normal human being maximum sweat is 0.5 liter per hour, 500 ml an hour. But if in case of accustomed workers, it increases up to 2 to 3 liters per hour. Plasma volume expansion occurs, and there is an improved cutaneous vascular flow up to 20 to 30 times. There is a removal of blood from the central part of the body. Heart rate lowers with a higher stroke volume. The cellular level adaptations are interleukins and heat shock proteins are produced. And then we have something called as critical thermal maximum for humans. There is a temperature for every species, namely in camels it is about 46 degrees. In humans it's about 42 degrees centigrade or 107.6 degree Fahrenheit. It is the temperature beyond which cellular injury starts to take place. So that is a very important. The most important thing, however, which needs to be understood about acclimatization is that it takes several weeks, but deacclimatization takes few weeks. So usually a laborer or an athlete performing daily, but taking a break of 1 week or 2 weeks and coming back from that break, starting to perform like he used to do earlier, that is the most likely case scenario for an exertional kind of heat stroke, because deacclimatization takes only a few weeks. So it requires reacclimatization for a person to resume his normal activities over a period of time. And then one very important thing which people confuse hyperthermia with is hyperpyrexia. This term should not be used interchangeably. Hyperpyrexia is an extreme amount of fever. Usually in the pre-antibiotic era, there was a limit to which actually fever is a protective response of body to prevent growth of pathogens in human body. So hypothalamus raises the human temperature. That is called hyperpyrexia. In pre-antibiotic era, the maximum went up to 106.7. That is hyperpyrexia. It should not be confused with hyperthermia, in which there is no change in hypothalamic set point. It is the imbalance between production and dissipation. Hypothalamus, skin, human body, all is wanting to dissipate heat and lose heat, but it is unable to do so because of it has been overwhelmed. So that is the difference between hyperpyrexia and hyperthermia. And in hyperpyrexia, although paracetamol has a role, in hyperthermia it has no role, none whatsoever. So the risk is a composite of hazard, vulnerability, and exposure. And risk heat stroke is cerebrovascular accident, myocardial infarction increase up to 10-fold in extreme heat condition. Preterm births and low birth weight babies, stillbirths are also have been shown to increase. And then vulnerability is extremes of age, obesity, malnutrition, people taking beta blockers, CCBs, calcium channel blockers, selective serotonin reuptake inhibitors, and diuretics. These are all prone, and these are very commonly used drug in hypertension and psychiatric illnesses. And substance of those people who take substance abuse are also very vulnerable in form of cocaine, amphetamines, even your alcohol also. And concurrent illness makes one more susceptible to heat-related illnesses, namely infections, decay, thyroid storms. In terms of exposure, as we all know, laborers, athletes, military personnel, they are very exposed to heat, and thereby their chances of exertional heat stroke are very high. So heat-related illness are an entire spectrum in itself, ranging from very mild, minor heat syndromes like prickly heat, miliaria or lichen tropicus, colloquially called as ghamori in Hindi, to heat syncope, to hyperventilation tetany, to heat edema and heat cramps. Whereas on the bit extreme end of the spectrum are heat exhaustion, followed by the maximum, which has a maximum killing rate, which is the heat stroke. So we are going to discuss them one by one. Prickly heat or the miliaria rubra or lichen tropicus or heat rash is a maculopapular pruritic erythematous rash in clothed area. We have all seen it. It is because of blockade of sweat pore by the debris from macerated stratum corneum. And the predominant symptom is pruritus. And the simple solution to it is giving some antihistaminics, betadine lotion, 1% salicylic acid can also be used. And to prevent it, we have to prescribe patient to wear breathable and loose-fitting clothing. Heat edema, some people have this mild swelling of hand and feet when, especially this is more so when the season changes, and then nothing has to be done about it. More just ask person to avoid heat, and it resolves gradually on its own in 4 to 6 days. Elevation and compression stockings may hasten up the process of recovery. There is no role of use of diuretics. They in fact harm by depleting volume. Then we have hyperventilation tetany. A person exposed to heat starts hyperventilating, thereby causing respiratory alkalosis, which decrease free calcium, thereby giving rise to a carpopedal spasm. We should not be in a jiffy to start calcium, intravenous or otherwise. We should just ask person to move away from heat and assuage him or her, and the cramps go away on their own. Rarely do we have to start calcium. Then we have something called heat or exercise associated cramps. These are also very common. If an unacclimatized individual performs a vigorous exercise in a humid, hot environment, then he or she suffers from profuse diuresis. And what happens is, if he is not accustomed to this, he replaces fluid loss with copious amount of water and not replacing it with adequate amount of electrolytes, thereby creating a condition which his body's osmolality becomes low. This gives rise to intermittent, painful, and involuntary spasmodic contraction of skeletal muscle. And it is usually a self-corrected condition. You can ask person to rest in cool environment and it gradually passes off on its own. If in case it doesn't, then we can use always oral followed by IV electrolytes. If we don't have access to them, we can simply ask patient to put half teaspoon in 1 liter of water solution of salt, and he or she can consume it, and it really goes away very fast. Then we have another condition called as heat syncope. In this, the typical history is prolonged standing in heat conditions, or even sitting in heat condition and suddenly standing from a sitting position. Then this condition is encountered. It occurs because there is a volume loss and peripheral vasodilatation, and as a person suddenly stands up or is continued standing, so there is a diminished supply to our brain, thereby creating hypotension and syncope. The treatment is very simple. Ask a person to rest in shade and ask him or her to elevate his or her leg and ask him or her to rehydrate. Then we come to this is important condition much higher in the spectrum of severity, which is heat exhaustion. We encounter two kinds of heat exhaustion, namely water depletion heat exhaustion and salt depletion heat exhaustion. Water depletion heat exhaustion usually occur in people who are accustomed to heat, namely laborers, athletes, military personnel. So they exert themselves in hot environment because they are kind of acclimatized, so they forget taking water. They don't adequately replenish fluid, neither water nor salt. So this is kind of this is seen in people who are acclimatized. So there is water depletion. However, if an unacclimatized person encounters heat, the first response is to consume large quantity of water or some hypotonic solution. So this produces salt depletion, heat exhaustion. The sign and symptom of heat exhaustion, which are a bit milder than heat stroke, but it is sometimes very difficult to differentiate between the two, are headache, vertigo, ataxia, impaired judgment, malaise, dizziness. It can also cause cramps. Sometimes it can cause gastrointestinal symptom like influenza and nausea. And then we can have severe symptoms in form of orthostatic hypertension and sinus tachycardia. Lab investigation, the diagnosis is essentially clinical, but nonetheless, PCV is high and electrolyte abnormalities can be seen on a lab investigation. AST and ALT are mildly elevated, unlike in heat stroke, which they are very severely elevated. And we have decreased amount of urinary sodium chloride as body is trying to conserve these ions. Treatment is very simple in form of removing the patient from a heat stress area, and aggressive cooling is indicated until the core temperature drops to 102.2. This 102.2 is important and one must remember it, because even in heat stroke, when we cool a patient, we don't cool him or her to 98.6 or 99 degree Fahrenheit. We cool him or her only to 102 degree Fahrenheit. So the core temperature, aggressive cooling is indicated till the core temperature drops to 102. Rapid infusion of isotonic IV fluids should also be guided by frequent electrolyte determination and perfusion requirements. And free water deficit should be replaced slowly to avoid a sudden decrease in serum osmolality, which can have its own set of problems. Serum osmolality can be calculated by a simple formula. This is very widely available formula. I've Indianized it. 2 times sodium plus potassium. Sometimes you can take only sodium also. Some people take plus plasma glucose divided by 18 plus urea divided by 6. In Western literature, you will find BUN divided by 2.3. I have converted it into urea because we Indians mostly deal in urea. We have urea levels. So we can always calculate serum osmolality, and the normal osmolality is between 275 to 295 milliosmoles per kg, and see whether a person is having low osmolality or not. Now, it is very important for all of us to differentiate between heat exhaustion and heat stroke, albeit it becomes very difficult sometimes. In heat exhaustion, patient is usually faint or dizzy with excessive sweating. And in heat stroke, he will have a throbbing headache and no sweating. But in case of exertional heat stroke, we can get a person who is having a heat stroke and drenched in sweat. So it is not entirely black and white. Sometimes it becomes gray. Cool, pale, clammy skin will be seen in heat exhaustion, and nausea and vomiting can be seen in both. Rapid, weak pulse is seen in heat exhaustion because of immense amount of water depletion or salt depletion. Heat stroke, we will have a rapid and a bounding pulse because of high pulse pressure, high systolic and lower diastolic. And the basic difference, between heat stroke, exhaustion and heat stroke is that heat stroke is a triad of 3 conditions, which is body temperature more than 40.5, CNS dysfunction, and history of exposure to a heat stress. Without these 3, we don't call it as a heat stroke. So we come to the most severe of all spectrum of heat-related illness, which is the heat stroke. We have 2 kinds of heat strokes, namely the classic, also called as the non-exertional heat stroke or the exertional heat stroke. Classic is usually seen in heat wave season, and it is seen in elderly on medicine, children who are usually sedentary in lifestyle. Whereas exertional is a sporadic kind of heat stroke, which can be seen, although it is usually seen in summers, but it can be seen in not so inclement weather also, not very high degree of because of overexertion. It is usually seen in young athletic people, and there is a clear-cut history of exercise or exertion. And in this case, unlike in classical, where anhidrosis is common, people are drenched with sweat. Diaphoresis is common. So CNS dysfunction is more common in classical, whereas in exertional we have CNS dysfunction is also there, but to a lesser extent. Myocardial hepatic injury, AKI, are more severe in exertional heat stroke. And rhabdomyolysis and dyslipidemia are also very severe in exertional heat stroke. So these are all the methods by which we can differentiate. But our focus should be on treatment, because the treatment in both prima facie remains more or less the same. So here are the some very important factors which determine prognosis. We have poor prognosis in heat stroke if the initial temperature is more than 106 degree Fahrenheit. The temperature is greater than 102 despite aggressive cooling measures. We are doing everything and still the temperature is not coming below 102. That is a harbinger of a poor prognosis. Then if the patient's coma duration is longer than 2 hours, he or she is having severe pulmonary edema, delayed or prolonged hypotension, and if we have lactic acidosis in patients with classical heat stroke, acute kidney injury and hyperkalemia also worsen the prognosis of heat stroke. AST and ALT greater than 1000 during first 24 hours are a sign of adverse prognosis. And we have high mortality in elderly with pre-existing disease or which are bedridden and socially isolated. One very important thing to note, which I have highlighted also, is delayed therapy mortality rate is about 80%, which decreases to 10% if we initiate early cooling measures. So this and such kind of meetings and such kind of sensitization makes all the more sense if we take home this very important lesson. So like I said, in case of heat stroke, we will have tachycardia and bounding pulse, which are wide pulse pressure. Sometimes we may have hypotension also, and this may suggest us a severe amount of fluid loss. This is seen in usually exertional kind of heat stroke, whereas there is fluid loss, dehydration. And another very bad thing is if it can be secondary to a myocardial damage, secondary to heat, and it may signal cardiovascular collapse. Blood pressure usually corrects with normalization of body temperature. We should not do anything aggressive. The first and the foremost treatment remains aggressive cooling measures. CNS examination is very, albeit on a higher degree, but very similar to heat exhaustion, namely irritability, delirium, confusion, delusions, convulsions. We can have cerebellar symptom in form of ataxia, tremors, dysarthria, nystagmus. We can have seizures, very common. Seizures, patient will be aggressive. These are the kind of scenarios which patient present to us with. We can, in a very sick patient, we can have decorticated and decerebrate posturing also. We can have cranial nerve abnormalities. And since it is a very important point to note, because a lot of time we may jump the gun and we may think that this is something else. So, namely other differential diagnosis which we are going to discuss in later part. The delirium tremens, in which we have ophthalmoplegia, encephalitis. So heat stroke in itself can also have cranial nerve abnormality. One very important thing again to notice, pupil can either be normal or be dilated or pinpoint. It can be reacting or non-reacting. So we can have every kind of presentation. It's very varied. And once in a while, we can have a person who can be lucid also. You cannot be entirely, you may be able to take a history also from them. So it has a wide range of clinical manifestation and one should be sensitized to all form and shapes. CVS examination, usually tachycardia, as I discussed, with decreased vascular resistance, a high cardiac index. Pre-existing cardiovascular disease, in case of pre-existing cardiovascular disease, we can have a low cardiac index also. And a hypodynamic state signifies a very adverse prognosis and may signal a cardiovascular collapse. CVCP is generally normal unless and until the patient is severely volume depleted, which occurs in case of exertional more than classical. And both high output cardiac failure and low output cardiac failure may occur. Nearly all other systems are involved. We can have GI hemorrhage and intestinal infarction. We can have hepatic manifestation in form of jaundice, raised liver enzymes, and we can also have bleeding disorders, namely DIC and bleeding, because all the enzymes which in the coagulation cascade are heat sensitive and they get damaged very easily. So there is no role of, as I'll discuss in next slide, of any other procoagulant measure, namely epsilon amyl caproxide. Nothing works except fresh frozen plasma. Musculoskeletal symptoms are in form of tenderness, cramping, rhabdomyolysis. These are more commonly seen in EHS or the exertional heat stroke. Renal manifestation are also seen in EHS more commonly. We can have AKI with high colored urine and oliguria. Pulmonary manifestation manifest themselves in form of tachypnea, hyperventilation. Sometimes there's a lung collapse and pulmonary infarction also. So we can have a bunch of differential diagnoses, very important to differentiate. Delirium tremens, we can have a short history of alcohol use and we can withdrawal. Hepatic encephalopathy, again, a proper history will help us. Hyperthyroidism, thyrotoxicosis, hyponatremia, meningitis and encephalitis, neuroleptic malignant syndrome, people taking antipsychotic medicines, salicylate toxicity, tetanus, snake bite, datura poisoning, cocaine overdose. These are all the things which we should be have in our mind while diagnosing a patient of having heat stroke. The diagnosis of heat stroke is essentially clinical, but lab investigation are done to rule out other things. We can do a CBC, which can show us leukocytosis and decreased platelet count. Serum electrolyte abnormalities also can be seen. One unique factor is nearly all have hypoglycemia. We should order a kidney function test, order urine analysis, which can show microscopic hematuria, myoglobinuria, RBC cast. Creatinine kinase is also raised. Liver function test, AST, ALT may rise up to 100 times. Coagulation studies should be done and it generally shows a decreased fibrinogen and prothrombin. ABG, VBG should be done to rule out metabolic acidosis or respiratory alkalosis. And lactate levels are usually raised. ECG can have variety of tachyarrhythmias, non-specific STT changes, and heat-related infarction can also be seen. And we should not jump to treat them with antiarrhythmic agents. Cooling should be first initiated. Chest X-ray can show the presence of, usually what we get is an ARDS kind of picture, but sometimes we can have atelectasis, pneumonia, and pulmonary infarction kind of picture also. CT scan basically is done to rule out encephalitis, intracranial bleeding, other things. It is not to diagnose heat stroke, but to rule out basically other conditions. Pre-hospital care is very, very important in heat stroke. We have to immediately, the patient must be removed from the environment. Cooling should be initiated by removing clothing, but this is in order to save time. It's not a mandatory step. Removing clothing, you should not waste time on removing clothing. If you are going in for evaporative cooling, then it becomes must. If immersion cooling is available and it's a better form of cooling, then no need to remove cooling at all. And placing wet towels or sheet over the patient's body, placing ice packs over neck, axilla, and groin. Patient should preferably be transported by a cold vehicle, air conditioned preferable, to the closest hospital. And now we come to management proper. The golden rule of management are cooling must begin immediately and must be continued during the patient resuscitation. The only treatment, the mainstay of treatment of either heat exhaustion or heat stroke is cooling, cooling, and cooling. Seizures treatment, cooling. We have to give anti-seizure medicine also, but basic treatment, cooling. Tachyarrhythmias respond dramatically to cooling. Hypotension responds dramatically to cooling. So I cannot place more emphasis than this on cooling measures. Rehydration therapy, this is very, very important thing. Lot of us try to treat heat stroke by giving fluids. So we must mark it in very clearly in our minds that rehydration therapy alone is insufficient for heat stroke patient. We will have to institute cooling measures. Surface and oral temperature assessments do not reflect accurate core body temperature, and the rectal is the preferred method. Being fast in start cooling saves lives, and antipyretics, as I discussed before, namely PCM, aspirin, or other NSAIDs, have no role. In fact, they have a detrimental role because liver enzymes are already deranged. And in emergency, although in exertional heat stroke, immersion cooling definitely has an edge on evaporative cooling. It has been proven in numerous studies beyond doubt. But in classic, also called as the non-exertional heat stroke, both are equally fine. Evaporative as immersion. But in emergency situation, we should not strive hard to make a distinction between the two. The treatment early initiation is of extreme importance. So this is very important thing. When I was discussing how to prevent people from going to heat stroke, is this very important slide suggests us. in lot of countries, they have mandated the use of wet bulb globe temperatures. So in case there is outdoor work going on and a laborer is working, and if the body is the temperature, wet bulb globe temperature crosses 90 degree, it is mandatory to take a rest of 45 minutes after 1 hour of work. If it is between 80 to 90 degree, then of 40 minutes after 1 hour of work. If it is 85 to 88, 30 minutes for 1 hour of work. And if it is between 80 to 85, 15 minutes of break per hour of work. This works better because it prevents heat stroke from happening, which is a very lethal condition. While researching on this, I came across some documents in which in periphery, some factories and construction site have this 3-flag policy: red flag, yellow flag, and the green flag. Green flag is always fluttering. If heat is somewhat unbearable, they hoist that yellow flag. If it is absolutely unsafe to work, they hoist the red flag on the topmost building of the site, so as to indicate to workers that it is no longer safe. We can plan to incorporate such practices in our country also. So acute management is the basic management is cooling, but I'll come to it last because I have saved the best for the last. So acute management comprises of initial resuscitation and treatment of complications, and how do we dispose and follow up the patient. Airway breathing circulation is very important for all the patient, and continuous core temperature monitoring should be considered in all patients. We have handheld devices in which, and the recommended length of rectal probe which should be inserted in a patient is 15 centimeter. That gives us the best measure of core body temperature. So ideally, we should have a handheld device, and we have such a device. We are in process, our hospital is in process of making a cold room for heat stroke patient, and we are procuring it. In the next 15-20 days, I think our cold room will be fully functional, and next time onward, I am going to present our own hospital's cooling technique. So this is a handheld apparatus. You have to insert the rectal probe up to 15 centimeter, and then it consists of 4 AAA size battery, and you can put, and continuous monitoring you should do. High supplemental oxygen has to be given. Fluid choice depends on the presence of hypovolemia, and we have to factor in all the metabolic and cardiovascular comorbidities. Cooling, like I said, alone may improve hypotension and cardiac function by allowing the blood to come to the center. And aggressive fluid resuscitation is generally not recommended because it may lead to pulmonary edema. It must be guided by CVP and pulmonary wedge pressure. So in those centers which have this facility, they must go in for this. Hypoglycemia, as I said, is a frequent finding and can be addressed by glucose infusion. Since peripheral vasoconstriction delays heat dissipation, so in case of we should preferably give discrete bolus of isotonic crystalloids for hypotension. And we should refrain insofar as possible from alpha agonist. If we require to use some vasopressor agent, dobutamine is the inotrope of the choice. Coagulopathy and hepatic injury is a very common. It usually occurs on first day of illness. Replacement therapy with FFP and platelets should be considered. And there is no role of epsilon aminocaproic acid. In fact, it increases rhabdomyolysis. So heat stroke patient presenting to us with bleeding, no role of Trenexa. We should not give him or her Trenexa. Seizures, that's a very important, yet another differentiation in how seizures are managed. Usually when a person comes to our emergency, we load him or her up with sodium valproate or Eptoin. These two things don't work in heat stroke because sodium valproate is metabolizes through liver, and we have to avoid giving it. Phenytoin doesn't work well. Barbiturate, one of the problems is they cause hyperthermia and they decrease sweating rate. One of the common symptoms of barbiturate poisoning is hyperthermia. So these are also to be avoided. The best course of action in case of heat stroke patient presenting to us with seizure is short-acting benzodiazepine in infusion form. Namely, we can use lorazepam or midazolam. Then we can have inpatient respiratory complication in form of aspiration, pneumonia. Usually we get ARDS. That is the most frequent presentation. We should initiate mechanical ventilation and positive end expiratory pressure. Dyslactotemia and hypoglycemia is to be corrected. Cardiovascular complication, like I discussed earlier, hypotension, we have to manage with fluid therapy, especially in EHS, exertional heat stroke, we may require a lot of fluids. Dobutamine and dopamine are preferable to alpha adrenergic stimulation, and tachyarrhythmias usually resolve spontaneously by cooling. We seldom require to use antiarrhythmic medication, cordarone or diltiazem, etc. Acute kidney injuries are very common, secondary to rhabdomyolysis, more common in EHS. The most common finding is oliguria, hypocalcemia, hyperphosphatemia, low sodium is seen usually, and a large amount of intravenous fluid, as high as 10 liters, along with alkalinization of urine and infusion of mannitol may be required. And in worst case scenario, we may have to use hemodialysis also. We can have GI bleeding or ischemic injury also. Now we come to the final but the most important part, which is the cooling strategies. There are two kinds of cooling: evaporative cooling and immersion cooling. We have incorporated them extensively in our national level guidelines, which we have drafted, and it is readily available on the ministry's website. So evaporating cooling is the most practical technique, although not very not the best one, but it is very practically effective. So what we do is we spray cold water or whatever water early we can lay our hands on the exposed skin, while we direct fans for a continuous airflow over the moistened skin. We can also apply cold packs to the neck, axilla, and groin, which are a usual cooling adjuncts because major vessels pass through these areas. Cardiac electrolytes are applied to back for continuous monitoring. And this is a preferred mode in classic heat stroke. This doesn't work well in exertional heat stroke. One more thing I would like to discuss here is there is no role of cooling blankets, cooling machines. This doesn't work. Evaporative cooling works better. And the best is immersion cooling because conductivity of water, like I said, is 25 times that of air. One problem which we had earlier, which people laid their doubts on, is start of shivering. If you immerse in water, shivering start. But the benefit of conductive cooling is really outlast and outweighs the drawbacks which the heat gained from shivering. That is very clearly proven in multiple studies. So it is the preferred option in EHS, but it can, like I said, induce peripheral vasoconstriction and shivering. This technique, however, is difficult in the sense that it provides significant monitoring and resuscitation challenges. So it has to be given with it requires a lot of logistical backup. But it is the best when it comes to young and previously healthy patient with exertional heat stroke. And we have to cool only up to 1 or 2.2. That is very important because there's a after drop also. And rate of cooling, commercial available cooling blanket doesn't work. Rate of cooling should ideally be 0.15 degrees centigrade per hour. So that we have to bring it down by that time. So, and commercially available cooling blanket don't provide cooling at such a express rate. So, IV infusion of cold fluid and cold irrigation of bladder can also be tried. If we can use cold peritoneal lavage, thoracic lavage. This is an invasive method. And if we have a cardiopulmonary bypass, these are all very, very, very rarely used methods. But nonetheless, it's important to mention them because they are mentioned. But the mainstay remains immersion cooling in case of EHS and evaporative cooling, or immersion cooling in case of CHS. Most patients with minor heat emergency syndromes, including heat edema, heat syncope, and heat cramps, require only stabilization and treatment with outpatient follow-up. In heat exhaustion, these patients can have multiple predisposing factors and comorbidities, which we should all pay our attention toward, and they will require prolonged observation and hospital admission. And the prognosis worsens if the initial core temperature is more than 107.6 or if there was a prolonged period during which the core temperature exceeded this level. Number of dysfunctional organ system also correlate directly with the mortality risk. So the take-home message is early confirmation of heat-related illness and initiating resuscitation ASAP in case of heat stroke. Cool first and transport second should be followed. Rapid cooling is of utmost importance. Mortality and morbidity are directly related to the duration of core temperature elevation. So we should do everything in our means to start cooling early. And close monitoring of vital parameters and early identification of complications is a must. So I will share with you some of the methods which we have given in our national level guidelines also. And I am hopeful that next time, if at all there is another webinar, I'll be presenting slides and demonstration for my own hospital. So in the meanwhile, we have to contend with whatever we have. So here are some methods with which immersion cooling can be instituted.
What would you do if you were out on the trail and saw a runner who was suddenly...
This is called TACO method, tarpaulin associated cooling oscillation.
Are you okay? Heat stroke can happen while running, camping, or at any outdoor event. Luckily, a tarp and water is all you need to cool them down.
Let's roll it. We need to get in this tarp.
Chris Sampson, an emergency medicine physician at University of Missouri Healthcare, helps us demonstrate the TACO method.
Now we need to put some ice on her and get water on her as well and pick up the tarp.
TACO stands for Tarp-Assisted Cooling with Oscillation.
The TACO method is very important for people who you may encounter that are confused, unresponsive, or passed out from the heat and will not wake up. These people often need rapid cooling in order to help save their lives.
If someone is unresponsive, get them onto a tarp. Pour water and ice on top of them. Then keep the tarp moving.
Most of your heat dissipation occurs on the surface of your skin. And by oscillating or moving the tarp back and forth and having that cold water get in contact with all portions of their body, you're able to get the heat off them in a more rapid fashion.
Think of this as a temporary cooling method. You still want to call 911. But taking action before the ambulance arrives could make a life-saving difference. From the University of Missouri, I'm Teresa Snow.
So this is TACO method, and tarpaulin we all know, assisted we all know, cooling, but the most important word here is oscillation. And similarly, you will see one more video, very short one, in which again it is very important to stir water when there is a patient in immersion cooling. Stirring water, oscillation, because then only heat dissipation occurs faster. This is yet another method when a body bag, by the ingenuity of doctors in the treating team, is from a end of life thing, they have converted a body bag into a saving life thing. See, they have zipped a person up to the neck in a body bag, put a lot of ice and water and rapidly cooled. It's a quasi immersion kind of cooling, saving a person's life by using a body bag, which is used usually to preserve dead bodies. This is an article on the body bag. So people all across the world have used ingenious method to initiate faster cooling in order to save life. And this is the last slide, which again comes to immersion cooling, one full-fledged immersion cooling.
Most effective way to cool an athlete is with full body cold water immersion. The procedure should go as follows. First, remove as much clothing and equipment as possible. Second, assess the rectal temperature of the athlete. If heat stroke is suspected, you want to immerse the athlete up to chest level in a tub of ice and water. There are three important considerations to implement when utilizing cold water immersion. One, be sure to store the water during the entire cooling process. This enhances the cooling rates. Second, be sure to secure the athlete with a towel or long sheet underneath the armpits to make sure the athlete does not slip into the water. And three, take them out of the water when their body temperature reaches 102 degrees Fahrenheit. To use this treatment effectively, proactive steps need to be taken by your team or league to ensure a tub is available at all practice sites. Because exertional heat stroke is a life-threatening situation, the proper equipment and emergency action plan are critical to getting the athlete's core temperature under 104 degrees in the most important 30-minute window. The key to surviving exertional heat stroke is rapid reduction of core body temperature, preferably cooling on-site. We encourage all organizations to develop a policy for administering this treatment.
So with this, I come to the end of my presentation, and the only one thing if you can take home is you have to differentiate. Fever is not hyperthermia. You should not confuse. Paracetamol is not the treatment for hyperthermia, and early initiation of cooling method. Something is better than nothing. Rather than chasing a elusive West, we should always do whatever good we have. Thank you so much.
Thank you, Dr. Ajay, for that elaborate presentation on clinical aspects in adults and emergency cooling. Dr. Tanu, is there any question? No, I don't see any question. I think if there is permission from Dr. Akash, we can move on to next speaker.
So, Dr. Purvi, I am removing my presentation. Okay.
Okay,
Yeah.
sir. Thank you.
Yeah. Dr. Shaw's presentation is visible to me.
Okay. So next speaker is Colonel Dr. S.T. Shaw, Senior Advisor from Army Hospital Research and Referral Hospital, New Delhi, and he will take session on heat-related illness management aspect in pediatric patients. So I invite Dr. Shaw to take the next presentation. Thank you, sir. Over to you.
Yeah, thank you so much, ma'am. Thank you to the organizers for giving me this opportunity. I'll basically be dealing with the pediatric part, and Professor Ajay Chauhan has already have gone into much detail, and it has done my job very easy because I don't have to go through that detail anymore, and I'll be mostly restricting myself to the pediatric part. Hope my slide is visible. I'm going to my next slide now. No, it's not moving. Yeah, just a moment.
Yes.
Let's do once more. Is it visible now?
Yes. I think it is. Yes, now. The first
Yeah,
one is
okay.
visible.
Yes. Okay.
Yes, move.
So I'm into my second slide now. So basically, what I'll be dealing with about the preventive part more, because the therapeutic part has been dealt much in detail, and it is more or less similar in children. So I'll be dealing with preparedness in schools, and about also increasing awareness in parents and children, because prevention is always better than cure. And of course, management of heat-related illnesses in children, which is similar like adults. So what facilities schools should have during this time? So whatever is written in the slides are actually very simple, but it is important that we ensure that these are there. So implementation is the key, and not the knowledge. It's by and large known to everybody about these things. So availability and accessibility to potable water. Remember, this will be summer, and there may be an issue of potable water availability there, and you have to somehow ensure that the school has it. Water coolers has to be clean, and it must be ensured that it goes through regular cleaning and monitoring. Many a time the children don't go to the water coolers because it is not clean, or they take water from home, but then it is not good enough. It is not enough for the children, but still they don't go to the water cooler because they have been told or they have seen that it is not clean. So these are important issues, because if it is not clean, they will not be having that water. Classrooms should be well ventilated, goes without telling that it needs well ventilated classrooms, and the cross ventilation should also be ensured. There should be enough ceiling fans or AC. This is the time, even like summer has already set in actually, but still we have some days time. So all the ACs and fans should be seen that they're working fine. Backup electricity is must during class hours, because it may so happen that the electricity has gone, and that time that much of heat and not enough ventilation can cause problem. And there should be one cool room inside the school, and a very easy solution to this is that a 1.5 ton for a 15 by 15 feet room. So if we can remember this much, this is good enough. So one cool room inside each school to be ensured. Next, what other measures should be there is that they should avoid plastic water bottles, and the students should avoid plastic water bottles. Then the school timing. Now, in summers, one must start early and close before the peak temperature. And what is the peak temperature? Generally, it is considered 12 to 3 p.m. So 12 noon to 3 p.m. So before that, if possible, the classes should finish, or if not, as early as one can. And so basically what we mean is that the school timings can be preponed so that it starts early and it closes also before the peak temperature. Then there is issue of games and sports period. So it should be flexible enough and based on temperature and humidity factor. Again, that 12 to 3 p.m. period should be avoided by all means for games and sports. And if that day temperature is high or humidity factor is high, then probably these sports altogether can be cancelled or can be done in under shade or some light sports kind of thing. So it's a lot of common sense involved in this, and the school authorities have to be very very considerate about all these things. So no major outdoor sports events during the summer months, and in case of excess heat, recreation activities should be indoors only. This is what we mean. Regarding the clothing should be comfortable. It should be loose enough, lightweight, light colored, and avoiding of neckties. So this is the time if the school has got a uniform where neckties are there, maybe neckties can be like kind of excused this time. And they should wear very, very comfortable, light color, lightweight, loose kind of clothes. Then is strict adherence to summer holidays and flexibility to prepone or postpone if need be. This is important because suddenly the temperature may go up. Generally, the administrative authorities do kind of give directions for holidays. But at times, it may not be uniform in every state. So the state authorities or district authorities should take a lead and should think about this, and can always prepone or postpone the previously thought summer holidays. That's what we mean. Some health awareness tips for students is that encourage more drinking of water by teaching the beneficial effects of drinking water, and if possible, water with added minerals, as heavy sweating removes salt and minerals from the body that need to be replaced. This has already been described by the previous speaker, that if possible, you can add some amount of salt in the water, maybe make some kind of nimbu pani, some salt, some water, some sugar in the water. So salt is very important. But it is important that they must know, the students, the children, that you have to take water even if you are not thirsty. So that is very important. What generally children do, that when they feel thirsty, they drink water. But here is a situation where it's already, they are very prone for some kind of heat related issues. So they should take more and more of water beyond what thirst they feel. This is very important. Now, it is also important that they avoid fruit juices, sugary drinks, or carbonated drinks as substitute for water. So they may feel that, okay, some kind of Coca-Cola or some kind of carbonated drinks is okay. No, it's not okay. Plain water is the best, in that some minerals, it is desirable. But definitely the fruit juice, sugary drinks, or carbonated drinks are not to be used as substitute for water. On the other hand, our Indian, things like shikanji or traditional Indian lemonade, aam panna, bel sharbat, they are fine. They can be given. They are good for children. Then there will be many health-related issues. The commonest one would be probably prickly heat. So with the heat-related illnesses, the children will be mostly suffering from prickly heat. So it is been mentioned in addition here, even though the rest of the conditions also I'll discuss. So this should be addressed. And the children should be taught the importance of bathing each day, because many children are kind of little fussy. They may not be, willing to take bath every day. but this is very important that during this time, bathing is done each day to prevent skin infections. Then it may or may not be applicable to schools, but otherwise, never leave children in a parked car, even if the windows are open. This is absolutely important. So before locking, look. So there should not be any child left in the parked car, because in summer, even if the windows are open, it may cause problem. And if windows are closed, then it is a like hot oven inside. And then if possible, wear sunscreen, broad spectrum, ultraviolet A and B protection. Yeah. And if not, use umbrella, hat once outside the shade. So these are very simple measures, but important ones that the students should know and the parents should know, so that they kind of guide the children to do all this. Now, about early signs of dehydration. So this is important for the school authorities, that how will they come to know that there is some problem occurring, there is some dehydration occurring in any of the students. So these are all the symptoms that the student may have, and the class teacher should be aware about them and should be looking for these symptoms in the students. So like if a student, has a symptom of feeling faintness, or is looking unduly tired, or is having intense thirst or fever for that matter, that he was outside the shade, was in sun and is coming and is looking feverish, headache, nausea, vomiting, not fast urine for hours, or the urine is concentrated. I'll show you a very simple way of knowing whether urine is concentrated or not. Then if the baby is, the child is breathing faster or deeper than normal, then also it is a sign of dehydration. Then skin numbness or muscle cramps. Okay, muscle cramps because of water and electrolyte loss that can happen. Dry tongue and sunken eyes. So any of them or in combination, these all signify early signs of dehydration, and important is that the class teacher recognizes them. It is very easy for doctors to recognize them, but the point here is that all these things, these simple issues, simple messages, they should be known till the parents, till the students, so that the earliest corrective step is taken. Now, this I got from Australian website, and I found it to be very good way of knowing whether a child is dehydrated or not. So what they do is that they give this kind of posters in the bathrooms or the washrooms, and it's written, "Am I drinking enough water?" So what happens is that when the child goes there and passes urine, he can see himself what is the urine color. Okay. So if the color is, let's say, between 1 to 2, that means the child is quite well hydrated. It's a pale, odorless, and plentiful urine, and it's an indication that the student is well hydrated or child is well hydrated. So they are the message for them is that keep drinking at the same rate. Now we go to the 3 and 4. Now it has become a little bit more yellowish. Okay, so it is slightly darker yellow urine than the previous one, and it indicates that you need to drink more water. So the message to them is that drink a glass of water now. Okay, I told you earlier that this happens is that the students or the children feel that when they drink water, more water than otherwise they have taken. So then we go to 5 and 6, and now you see the color is becoming a little darkish yellow kind of. So it's a medium dark yellow urine, and it's an indication that the student is already dehydrated. So now the message should be that one should drink 2 to 3 glasses of water now, and not drink a glass of water, 2 to 3 glasses of water. The last one is 7 to 8, where you have darker and strong smelling urine, and in very small amount. This is a sign of dehydration. Now the message is that drink a large bottle of water immediately, and also to report. Now it's a red flag sign. Okay, so now these are general guidelines, and of course medical personnel should see after when somebody is in 7 to 8 zone, or even before that. The class teachers also kind of see the child. But point is that this can be a very simple method of the children only knowing that whether they are dehydrated or not. Now, just 2 disclaimers here is that sometimes certain foods, medication, and vitamin supplements may change the urine color. even if a child is hydrated. But by and large, this is what happens when the child becomes dehydrated more and more. And second thing is that these posters do not replace the advice of a health professional. So in case one is in that 7 to 8 zone or maybe 5 to 6 zone, it is always better to speak to the class teacher and followed by the medical authorities. Now we come to the heat-related illnesses in pediatric age group, and they are similar in adults, but some are more common, like heat rash, milia rubra, or prickly heat, whatever you say. So I'll discuss both the treatment part and the prevention part. As always, in pediatrics, prevention is considered to be very, very important, in fact, better than cure. Treatment-wise, more and more should be placed in a cool environment. Remove excess clothing if they have, and avoid any application of lotions. Most of the lotions don't help, except maybe calamine lotion. The prevention part is that one must wear loose fitting clothing and remove any excess cloth. The students or the children must avoid direct sunlight, and excessive heat should be avoided, and frequent fluids, and if the baby is being breastfed, frequent breastfeeding should be done. So this problem will be there from newborn age group till the bigger children. So all of them can have it in case it's a newborn baby or an infant who is being breastfed. So more and more breastfeeding should be done. And in case it's a bigger child, so more and more fluids should be given. Next is excessive irritability and dehydration, and the treatment is again placing in a cool environment, removing excessive clothing, and frequent breastfeeding of fluids. It remains the same. Then is something called heat edema, which was already described in the by the previous speaker, where swelling of feet or ankle happen. And the treatment again remains the same, that remove from hot environment and place in a cooler environment and elevate the affected extremity. Generally, no drugs are required. Next is heat cramps, and heat cramps are more common in those children who are running around or in the young athletes. Here what happens is that it's a painful, involuntary, spontaneous contraction of muscle group of legs, calf, or groin, and it's pretty painful. So the treatment again is that you remove from hot environment, and as was again and again emphasized by the previous speaker, that coming back from the hot environment and keeping the child or the patient in a cooler environment is a must. Rest everything comes later. Of course, the rehydration will also is required here by providing frequent oral fluids and if possible, some salt in that. And if it persists, then even intravenous fluid may be required. Next is a condition called heat syncope. And basically, it is seen with prolonged standing in hot environments that causes vasodilatation and so a fall in blood pressure due to venous pooling in the legs. And this particularly pooling of venous pooling in the legs causes a decrease in venous return to the heart, causing a fall in cardiac output. So this will result in fainting or feeling lighthearted. So what is the treatment? Treatment, again, the first treatment is always removing the child from a hot environment and oral rehydration with salt-containing fluids. So ORS is a very nice thing, and probably in schools also they should keep lots of ORS, and at homes also one should keep ORS. Lassi will do, Nimbu Pani is fine, lime water with salt and sugar, rice water, dal water, coconut water, sattu water, all of them will do. Here, the oral rehydration with salt-containing fluids is considered to be the best treatment after removing the child from a hot environment. Next condition is heat tetany, and it can be differentiated from heat cramps by the fact that there is very little pain or cramps in the muscle, but tetany is developing, and a beautiful picture was there in the previous by the previous speaker. So the treatment again is that you remove the child from a hot environment and calm the child to decrease hyperventilation, because hyperventilation will cause ionized calcium to go down. And intravenous calcium after the child is admitted in a hospital is the treatment for this. So here, again, removing the child from hot environment, calming the child to decrease hyperventilation, and IV calcium is the key, other than rehydration. Then comes your heat exhaustion. And here what happens is that after prolonged heat exposure, the body temperature rises up to 104 degrees Fahrenheit. and leads to dehydration, tachycardia, vomiting, nausea, fatigue, and headache with normal mental status. So sometimes mild confusion may be present, but by and large, the mental status will be normal. So this is heat exhaustion. So in heat stroke, there will be an abnormal mental status, and the temperature will go more than 105 degrees Fahrenheit. Or the treatment is that again you remove the child from a hot environment, oral rehydration with salt containing fluid as much as one can. Look for dyselectrolytemia in case the child is been able to be admitted, then look for dyselectrolytemia. Here intensive care monitoring is required and IV rehydration is desirable. And in such situations, you rule out sepsis as well by sending investigations. The last condition is heat stroke. It is the last condition, but it is the most serious condition. And this basically happens because of prolonged exposure to heat that leads to core body temperature rising to more than 40 degrees. I'm sorry, this is 40 degrees centigrade. And patient presents with stupor, coma, drowsiness, confusion, delirium, hallucinations, seizures, ataxia. So all these CNS symptoms. Then anhidrosis. In the previous conditions, there will be more sweating, but here it will be anhidrosis. There can be coagulopathy and multi-organ dysfunction. This is a very serious condition. I'm sorry for the mistake there. It's more than 40 degrees centigrade or more than 105 Fahrenheit. So what is the treatment? Here is a condition, this child cannot be managed in the school or in that place and must be admitted and must be even though the cooling must start there, and if the child is not is having relatively okay sensorium, then only you give oral fluids. Otherwise don't give oral fluids, or that child will choke and can aspirate. Make all arrangements for admission. Try for an AC ambulance to take the child there and start your cooling from the spot itself. Once the child reaches hospital, you check airway, breathing and circulation, and give oxygen. In this case, IV fluid correction is best. And here you have to send many investigations like random blood sugar you have to do, arterial blood gas to look for metabolic acidosis, electrolyte imbalance, which is very common in this case, and sodium, potassium, and calcium all can be deranged. LFT must be sent, renal function test must be sent, coagulation profile should be done, and neuroimaging in case there's a suspicion of CNS bleed. We will see the exact flow chart how to treat heat stroke in a different document. I could not incorporate in the PowerPoint, so I have not done it. Before going to the document, the last slide are the danger signs. And the danger signs in a pediatric case are these. They is refusal to feed if the child is not feeding only and neither drinking. There is excess irritability. There is decreased urine output, dry oral mucosa, and absence of tear or sunken eyes. So these are some very important symptoms. Like decreased urine output is known to all, but then oral mucosa drying and absence of tear. The child is crying, but there is no tears. So it's a sign of dehydration. Sunken eyes, lethargy or altered sensorium, seizures or bleeding from any side. In such a case, these all will be considered to be danger signs. So I will just show one more document. Again, it's all there in the website. But still, I thought this should be a good occasion to show this clinical workflow. And after this, I'll stop. So basically, can anybody just let me know that you can see the clinical workflow or not?
Yes, we can see, sir.
Yes. So this has been taken from the document that is there in the ministry website. And just one document that is very important for all the doctors to know, that how to manage heat stroke in a child. So once you have confirmed it is heat stroke, then you take the child to the hospital. As I said, the cooling must start from the school or from the spot where the child was detected to have heat stroke, and take in an AC ambulance to the place to the hospital. There you assess airway, breathing, circulation, and neurological impairment. You ensure IV access and send all relevant investigations. Consider intubation if necessary. Consider benzodiazepines, and as informed in the previous PPT, is that this midazolam or lorazepam both can be given. Midazolam and lorazepam, both the dose is 0.1 mg per kg. Give over 3 to 5 minutes. Give for seizures and also for excessive shivering. For both benzodiazepines can be given. In case the child is in shock, then give saline bolus at 2 ml, 20 ml per kg, and you reassess. And these boluses can be given up to 60 ml per kg. But see that there are no features of fluid overload, like liver size keeps increasing or pulmonary edema happening. So be aware about that. And as was categorically told, that cooling is very, very important. Once the cooling is done and the peripheral vasodilatation go, the fluid will come back. So there's always a chance of fluid overload in case we are just indiscriminately giving fluids and not doing cooling. So cooling is a must, and cooling, the methods that was described in the last PPT, the same is done for pediatrics also. I mean, you remove the clothes if you can, of course, maintain dignity. And even if the clothes are not removed, you just sprinkle water over it, whatever cool water you can get, 15-degree temperature, or even normal water also is fine. And just put fan on the child. If there is AC room available, take the child to AC room. If there are ice available, then put ice on the groin, on the neck, on the axilla. All these things you have to start from the beginning. And then the child has to be taken to the hospital. And in case there is no shock, then you just assess dehydration status and correct and start normal maintenance fluid. And I'm sure the normal maintenance fluid everybody knows is that for the first 10 kgs, it is 4 ml per kg per hour or 100 ml per kg per day. You divide it into hours, so then it becomes 4 ml per kg per hour. And in case 10 kilo plus child, so let's say 10 to 20 kilos, so then for them it is 2 ml per kg per hour. So let's say a 15 kilo child. So first 10 kilos, 10 into 4, that is 40. And then for next 5 kilos, it is 5 into 2. So 50 ml per hour will be your fluid instruction. And in case the child is 20 kilo plus, then for every kg, you add 1 ml per kg per hour. I hope I'm clear. First 10 kgs, 4 ml per kg per hour. Next 10 kilos, 2 ml per kg per hour. Next, beyond 20, it is 1 ml per kg per hour. So that should be your fluid prescription. Then you also, as I said, the cooling measures have to be taken from the spot itself, from the school or anywhere. So their removal of all clothing while protecting patient's dignity, covering with thin wet sheet and spraying cool water, ice pack over head, neck, groin, and axillary regions. Use mist fan or evaporative method. Tepid sponging, cool blankets if available, but it is better that we do this mist fan or evaporative method. Make the child lie down and raise the feet slightly. This will also help in fluid from the legs, the whatever the fluid is there in the vessels in the leg will also come into the central circulation. You avoid paracetamol or NSAID. This is very, very important. Will do more damage than good. And if required, even gastric lavage with cold saline can be done. Next is close monitoring, which is very, very important, is that we check temperature every 15 to 30 minutes and do not overcorrect to less than 38. So as was previously also told, that your 102 is the cutoff. So below 102, let it happen gradually. You don't have to target 98. So, and rectal temperature, it may be difficult to get. Even axillary temperature will also do in such scenarios. And remember that hypothermia is also bad for children. Vital signs like BP, heart rate, and saturation should be seen. Watch for altered cardiac rhythms, ECG, and altered mental status by Glasgow Coma Scale. And Glasgow Coma Scale is different for children. Look out for complications of treatment, as I said, acute pulmonary edema because of excessive fluid and hypothermia. Seizures, as I said, midazolam and lorazepam, very easy to remember. Just remember 0.1 mg per kg per dose is the dose. If you don't remember, if you can't remember anything, both midazolam and lorazepam can be given at 0.1 mg per kg per dose. Give over 3 to 5 minutes. Prevent shivering. If the child is intubated, one can be a paralyzing agent can be used, or even better is just using midazolam or lorazepam. That will also help improving shivering. Look for signs of coagulopathy because it is common, and in fact, if there is clinical bleed from various orifices, then it's a very bad sign. ABG should be done regularly to look for metabolic acidosis. CT brain to look for complications or to rule out intracranial pathology. Continue management and referral to ICU. and inform or communicate with next of kin regarding patient condition prognosis. This is often a neglected kind of thing, but very, very important for children because parents are very, very anxious when a child is not well. So, ma'am, that is all from my side, and I think I'm almost reaching time also. So I'm stopping sharing of the documents. I'm done, ma'am, from the pediatric side.
Okay, thank you very much, sir. Do we have any questions, Dr. Tanu, that we can address?
No questions we see in the last. We have just a, we can see.
Nothing? Sorry, I could not hear.
Yeah, no questions. So I can see in the chat. If anyone in the audience want to ask questions, they can write, text us, or they can raise their hands.
Okay. So by the time anyone think of question, I'll just like to highlight. First of all, thank you, Dr. Ajay, and thank you, Dr. Shaw, for taking the session today. We will also have a session tomorrow for people or colleagues who have missed today's session. You can inform them to join again tomorrow. Similar schedule is planned. I have also put some links to the documents that were discussed as in the first talk we mentioned about emergency cooling. So the link of our guidelines on emergency cooling is put in the chat box. Also with the other guideline for health facility logistics to acquire different equipments on that. And also a national action plan on heat-related illnesses that was shown by Dr. Shaw with the clinical protocols in it. All of these documents should help you on the different aspects of planning, provisioning, and management of heat-related illnesses, especially heat stroke. And as we all understood that it is the most fatal condition, and cooling should be the first priority of the in that case, and it usually helps with all the other aspects of health in terms of like change in blood pressure or heart rate. All those things cooling should be the first priority. So cool first and transport second is our priority. Lastly, I would like to highlight that recently we have also come up, we have disseminated a tool to assess the health facility and ambulance preparedness under public health facilities, and I'll just post it in the chat box here. So many of the states have taken initiative to fill up the form and review their assessment over the time. So all the other facilities who have not done that, medical officers and health administrator can go about it. It's a Google form to assess the preparedness, and I will put it in the chat box here. So that is being disseminated with the permission of Secretary Health and also support from DGHS side. So if we have any question now, Dr. Tanu. I don't see any raised
Yes,
hands.
we can see questions, 2-3 questions in the chat.
Okay,
Dr. Ajay.
Which fluid should be preferred for IV? So
This question, hello.
yes, sir.
This question we got when this was one of the more common questions asked when we did our offline presentations also. Fluid choice will have to be decided keeping in mind concurrent metabolic condition of a patient. If a patient is having CKD, you have to, or diabetes, you will have to choose your fluid according to the condition of the person or comorbid conditions. But if a person is absolutely hale and hearty, doesn't suffer from any comorbid condition, normal saline, DNS, ringer lactate, these are perfect fluids for this thing. These stroke, all three can be chosen.
Okay. Thank you, sir. Now next one is How much time we need to keep ice packs, intermittent or continuous?
Your voice is breaking up. Hello.
Okay.
Is the question
Yes,
directed
so
to?
no, so there is no directed question. It's just question in general for how much time we need to keep ice pack, intermittent or continuous. So maybe Dr. Shaw can also answer.
Yeah, so basically, your target already like informed target is 100 to no. So till that time, you have to use whatever means you have basically. Okay, so if you have an AC room, please take child or the patient to AC room. You sprinkle water over clothes and you use a fan. You use ice over neck, axilla, and groin. So all these things you have to do till the temperature is 102. So after that, it goes slow. Then it is you can go slow, and then simultaneously your fluid rehydration and will start. So the answer is that the target temperature where you should go up to is 102 and then go slow. That's what it means.
Dr. Ajay, what about in adults? Any comment or specific comment for adults?
Intermittent or continuous? You want to ask?
Yes.
There is no role. Intermittent cooling is, I never came across such a term. You have to continuously cool a person till his or her temperature reaches to 102. The essence is to get him or her to 102 as quickly as possible. That is the whole hallmark. Why should we do it intermittently? Why would we should not be shying away from cooling aggressively? That is the whole point of presentation. One more question is that why should we only cool up to 102? Somebody has asked this also in the chat box I was seeing. Because there is a after drop also. It is not only cooling. Once you start cooling, a whole host of other functions start in the body. Namely, the most important of which is shifting of fluid from periphery to center. So you cannot go on cooling. Otherwise, it will lead you from one end of the spectrum to another end. If you cool up to 98 and then drop, the process will stop at 95 or 94. It will continue to cool. That is the reason we stop at 102 in immersion cooling. And the process by which, because of change or shift of fluids, it automatically reaches up to the desirable level. That is why it is only done to 102. And there is nothing like intermittent cooling. We should cool fast. Okay, the point which one needs to remember is not intermittent but oscillation. There's a TACO, tarpaulin associated cooling oscillation. Or while immersion cooling, you have to stir the water. Why? Because you want to increase the surface area, contact surface area. By stirring the water, once the skin starts to dissipate heat, by stirring, there is a uniform temperature of the water and the heat dissipation is much more faster. So all the methods are designed in such a manner that the hyperthermia is, we have to bring the body temperature down ASAP. So there is cooling has to be continuous and it has to be started as soon as possible. With even, like I said, we should not be chasing that elusive best, which compromises our good. You start off with good,
Whatever.
and then you can graduate up to the best.
Okay. Dr. Shaw, you want to add something?
No, the same thing. I totally agree. Like it has to be started at the spot itself and whatever means you have. So if ice is not there, you have water in normal temperature. Please use that. Please use a fan. AC is not there. Use the fan. I mean that kind of thing. Whatever means you have, just cool down the patient. That's all.
Somebody who is starting to use you must have started this body bag cooling for the first time. Think, he would have done it on it's a new novel method. The essence is of all this cooling methodology, may be taco or body bag, is a great Indian word called as jugaad. If you can see, this is a common thread. Whatever you can lay your hands on, whatever comes first, but the cooling has to start early. That if there is a single point, I am sure Dr. Shaw would agree with me, you have to start cooling early.
If you are unable to access even water, you ask the kid or the adult to lay and rest in cool shade. Then you lay your hands to water, you start water and evaporative cooling. Then you can immerse, you have access to a tarpaulin, you start taco method. That is the whole, because the essence is this heat stroke you will not encounter them in absolute hospital conditions. You may become, our RML or big hospitals of Delhi may have 5-star facilities, but where the heat stroke will happen, it will be a remote village. You will have to arrange. That's the reason now we are in process of developing one heat stroke room in our hospital, and we are designing in such a manner that we have a mobile element also. Besides the statics, we are purchasing tubs and ice and that whatnot. But we have a mobile element, inflatable tub. So if you are we are giving cover to a marathon, say. So we should have something which we can take from periphery. We can have water from source, and then ice we can carry of our own. So a lot of ingenuity is required. But the bottom line is start to cool early. That is the bottom.
Okay, thank you, sir. So in view of all this question, I would just like to summarize few of the points because we developed this guideline and I was also privileged enough to read all these things. So I will just summarize for everybody. So heat stroke is one of the time critical conditions. So some of the very few conditions which require immediate cooling or immediate assistance or treatment, heat stroke is one of them. So within 30 minutes of within 30 minutes you need to start cooling. So that is a time critical part of it. Second, because of this, we are also advising that on-field cooling, on-site cooling is important, and that is why ambulances are also being equipped to treat the patient in the field. And on public health aspect, if we think about this, again, mass gathering events are very important to be tackled with the viewpoint of heat, management of heat and heat stroke, because in many of the field conditions, we need to treat these patients immediately. So again, the mass gathering preparedness and ambulance preparedness should focus on treatment of heat stroke and immediate cooling aspect of heat-related illnesses. Another point, because we discuss ice pack. So for traditionally, we have seen that ice packs picture that it is placed on the six locations on the body and just patient is there. But it's not that. We need to now, because the impact of heat is that we have to prepare to even, not just keep them there, but actively moving them, replacing them so the patient keeps cooling and not just being passive. By the time patient cools. So that active part of cooling is very, very important, and all this is highlighted in the guidelines that we have prepared in that stuff. And second point I have to highlight is many times we think that ACs and fans are workable solutions to cool patients, but now we realize that they're not enough. They just cool a person who is healthy and waiting in a waiting area or some aspect. But once patient is on heat stroke, the cooling with AC and fan, expecting that is not sufficient. It will not cool. So active measures by spraying or ice cube placement, active fan air movement on the patient is very important. So these are some of the things that I had learned and seen, and now that we actually enter into the situation where we have to actively cool patient, this should be, I think, highlighted. So these are some things, summaries from my side. If there are no other points, I think we can close. And thank you, everybody. I hope you learned something, and the guidelines are available on the website. So thank you, Dr. Ajay.
Thank you, Dr. Purvi.
Thank you, Dr. Shaw. Thank you very much.